Thank you so much all for joining today's webinar titled The Role of Chest X-ray in Diagnosis, Treatment and Prevention of TB in Children and Adolescents, the old and the new. My name is John Paul Dongo. I am the co-lead for the COE platform with my colleague, Britton Moore at CDC Global TB Branch. But before we really get to start today's session, I'd want to go over a few items. Please, could we just mute our mics so we can really get on with the session? Thank you. So before we get started, I'd like to go over a few items so you know how to participate in today's session. You may have joined the presentation using your computer speaker system by default. However, if you'd prefer to join over by telephone, just select phone call in the audio pane and dial in. Information will be displayed. Please ensure that you are all on mute during the presentations, and when you are not speaking, there will be opportunities for questions at the end of the presentation. We'll save all our questions and discussions to the end of the session, but we'll also be able to discuss chest X-ray films from all your respective countries, as previously mentioned. You'll also have the opportunity to submit text questions to today's presenters by typing your questions into the chat panel. You may send in questions at any time during the presentation. We'll also collect these and address them during the Q&A session at the end of today's presentations. For the Q&A session, we'll open the floor to allow discussions on the points raised by today's speakers, as well as to share some experiences from a number of our Center of Excellence member countries. We'll also be able to record this session that will circulate later to all of you, but also this session will be posted on our COE page on the Union website, where you can always log in and be able to listen to the session. So it is really now my pleasure to introduce you to today's chair, James Seddon. James is a reader in Global Child Health at Imperial College, London, an associate professor at Stellenbosch University, and a consultant in pediatric infectious diseases at St. Mary's Hospital in London. His major area of research is that of children with TB, and he works on TB diagnosis, TB therapeutics, advanced imaging for child TB, drug-resistant TB, TB meningitis, adolescent TB, and TB burden modeling and the evaluation of TB biomarkers. James studied medicine at Cambridge University and Imperial College London, and has trained in pediatric infectious diseases at Centers of Excellence in the United Kingdom, with extensive clinical experience in resource-poor setting. James, you're most welcome, and thank you so much for sharing today's webinar. Over to you, James.
Thank you very much for that very kind introduction. It gives me really great pleasure to sort of chair and facilitate this session, and I hope it will be a really useful and informative session. And so really I'm going to take the opportunity to first of all introduce the first speaker, who's Professor Stephen Graham, who is a good friend and colleague known for a very long time, and I think many people in the school know Steve well. Steve has extensive experience as a clinical pediatrician and an academic researcher. He's worked throughout the world, spent a long time in Malawi doing research with his sort of boots on the ground, and has also been involved in multiple studies in multiple African countries, including in Uganda. He works a lot in the Asia Pacific region, in Southeast Asia, and is based predominantly in Australia. So it gives me great pleasure to introduce Steve to give an overview of the context of using chest radiology when diagnosing TB in children. So over to you, Steve. I think you're muted, Steve. Are you okay to share your own? You're still muted. Are you okay to share your own slides? We can't hear you. I think you're still muted, Steve.
Yeah, I've got a small problem. I'm not sure what I'm meant to do.
If you want, we can share. If that would be.
Yes, please. You've got my slides.
Let me just.
This is. I'm sorry about that. There we go. Thank you. Okay, so yeah, thank you very much, and I'm very sorry about that. If I can ask you just to advance the slides. So my main aim is to provide an overview and perspective on the role of chest X-ray. So yeah, next slide, please. And I'll start by sharing some context. I think you're aware, and this is why we're all here really for this. We've come together as a centre of excellence in the region. Is a major issue is to address the case detection gap for TB, and that's particularly a challenge for the young children under 5. And in that group, we know that a clinical diagnosis with radiology is commonly required next. And these are a high-risk group in terms of challenges for detection, but also for mortality. I will also highlight the potential role of chest X-ray in the evaluation of children who may require tuberculosis preventive treatment. There is a major gap as well in prevention, many missed opportunities. Only about a quarter of children who require preventive treatment, who are household contacts under 5, actually receive it each year. But also we now have recommendations that include older children and adolescents contacts to access preventive treatment. And I will highlight a little later on perhaps the importance of chest X-ray in that context as well. Next slide, thanks. The other context I wanted to highlight, which is really critical to our thinking here, is that most children with TB don't present to level 3 facilities that have lots of resources, including chest X-ray. There is often chest X-ray at level 2 facilities, district hospital level, but the problem of not having the diagnostic capabilities at the lower levels of health facilities is a real problem, because the numbers of children who actually get diagnosed is much reduced. And then next slide, thanks. And if we can address that by strengthening the diagnosis of TB at level 1 and level 2 facilities, we'd have a much greater coverage for diagnosis, and most importantly, many more children would be treated for TB. And this is what was shown by the Detect TB project in Uganda so nicely, where at the start of the project, 95% of the children who were diagnosed with TB were being detected at a level 3 facility, but after the project was implemented, it was more like 50-50 at other more decentralized services, which led to an increase in case detection and better treatment outcomes. And chest X-ray is really critical in this context. Next slide, thanks. So in terms of the chest X-ray itself, I think we understand the role of chest X-ray primarily, and most commonly, I guess it's used to support clinical management decisions, and importantly, decisions to treat for TB. It's also used particularly in child TB research studies to help define clinical TB. It can be used to rule out when TB preventive treatment is considered, to rule out active TB disease. And that's certainly the common practice that we have here in Australia in the TB clinic. Children who are considered for preventive treatment often have a chest X-ray. And it is more and more used now that there's a greater focus on active case finding in TB endemic settings and populations as a way of reducing the TB burden. Community active case finding, it's used as a screening tool in that context. But we know that it has many limitations, diagnostic and technical limitations, especially in its use for children. Next slide, thanks. So what type of TB are we able to diagnose when we use chest X-ray? Well, many of the cases in young children are intrathoracic TB, and the commonest being pulmonary TB, being the majority that's not bacteriologically confirmed. But there are other forms of extrapulmonary TB, such as Milory Tb or TB effusion, that can be diagnosed with chest X-ray. And importantly, the clinical and the radiological spectrum changes with age. I'll talk more to that. Next slide. The rapid development of diagnostics for TB in children happened a long, long time ago, and we're still waiting for better rapid diagnostics. But in the meantime, these are still some of the approaches that we rely upon, including chest X-ray. And just to illustrate that, in studies we've done in Malawi and Papua New Guinea over the years, in terms of diagnosis of TB in children, we know that more than 90% of the children who are diagnosed at the secondary care level with pulmonary TB had a chest X-ray. So very, very commonly used, even with the limitations. Next slide. Now, there have been some improvements since the days of smear microscopy with improved diagnostics, but we also recognise that though expert is commonly recommended as a primary diagnostic for TB in children, it has a low sensitivity compared to its use in adults. And in research studies, the sensitivity may be around 30%, but in actual practice, in programmatic settings, it's often quite a bit lower than that. And in outpatient settings, it's lower than in inpatient settings because of less severe, perhaps less advanced disease. So we all understand those limitations. Hence, again, we rely heavily on chest X-ray. Next slide. So the union developed a desk guide, which was really very explicitly aimed at the primary and secondary healthcare settings, where health workers often didn't have a lot of training in child TB and maybe not a lot of confidence to make the diagnosis. And it was really an effort to ensure that children had appropriate management. First, if they were very sick, to be referred for inpatient care, whatever the diagnosis may be, and to have their investigations as an inpatient and treatment. But also to perhaps detect the more straightforward cases of TB that could be diagnosed and effectively treated at the more decentralised setting without unnecessary referrals to the tertiary setting. And you can see in this one particular approach, you can see that chest X-ray is included. And if it was included along with, for example, positive contact history or physical signs, then this would push towards a diagnosis of TB if there was no sputum sample that was positive or available. Next slide. Now, this is a really important slide, and this was put together by our chair, James Seddon, and this just highlights what we all know, that it's really relevant to the radiological presentation of TB in children. In young children, and we could say in those children under 10, there's a tendency for more likely to have disseminated disease and lymph node disease. Disseminated disease illustrated in the top chest X-ray, lymph node disease in the second one. And often these are not bacteriologically confirmed, but severe disease and require treatment. And then as you move towards adolescence and older, the risk for TB again starts to go up, particularly in older adolescents, but the pattern of TB changes and the X-ray changes are more similar to adults, as you can see in that bottom chest X-ray.
Yes.
Next slide. Now, lymph node disease is a really critical part of the presentation and the radiological detection of TB in children. And this is just diagrammatic illustration of lymph node disease, lymph node enlargement, and the consequences, for example, on airway compression or rupturing of the lymph node into the airways and leading to bronchopneumonia, and lymph node disease with expansile pneumonia. But the primary pathology is often the peripheral infection with the more central lymph node enlargement. And we rely a lot on detecting that lymph node enlargement in our radiological interpretation, particularly in younger children. And as I said, we can also detect disseminated disease or effusions. Next slide. So Robert Gee, who's a mentor of James and Megan, who are presenting, he's put together in 2003, at the same time as the Child TB Union WHO working group was formed, he put together an atlas. Now, this atlas was really aimed to illustrate the most common, clear child distinct forms of TB that present in young children. It was also developed at a time when there was a lot of high HIV prevalence in children with TB, and not in prior largely to the use of antiretroviral therapy, and the diagnosis had become quite challenging. Radiological diagnosis had become quite challenging, particularly in HIV-infected children, but also there was still not a lot of confidence in making a diagnosis of TB from chest X-ray in HIV-uninfected children. And this is a very important piece of work, and has been widely used, freely available. And it's this atlas which has now been upgraded and expanded, and Megan will talk to that in the next presentation. Next slide. In terms of recent updates with WHO guidelines, there's a number of updates that are relevant to chest X-ray and diagnosis, which I've listed there, and I will spend a little bit of time on the integrated treatment decision algorithm. But also, chest X-ray is going to be critical in the decision to use a shorter regimen for children with non-severe TB, and Megan will talk to that. Because one of the characteristics that are involved in the definition of what is non-severe pulmonary TB for children where it may be indicated to treat for just 4 months includes radiology. So there's also critical, as I've already said, is if we're going to be able to implement decentralized and family-centered or integrated models of care for detection and provision of preventive therapy, we need to strengthen the use of chest X-ray. Thank you. Next slide. Now, the background on the new treatment decision algorithms is that they were developed after the guidelines development group by evidence reviewers in consultation with a subgroup. Now, James should be talking to this because he was one of the leaders of this, but if I can just explain, this work was led by Ken Gunasekera and James and quite a few others, and the aim was to develop algorithms for treatment decision algorithms, and they decided to try for settings with chest X-ray and for settings without chest X-ray. And it was really aimed at the primary health care or primary care level to build confidence and capacity to make decisions on starting treatment, similar to the union's desk guide approach. And they did actually use actual individual patient records, a large number from diagnostic studies, and were able to determine the sensitivity and the specificity of the approaches. And you can see that settling on approaches that had a sensitivity of around 85% and a lower specificity, with the balance of really making sure that children with TB were detected and treated for the best possible outcome, knowing that there would be a certain number of children who did not have TB and would receive TB treatment And that was the balance that was agreed upon and required. And like in the Union Desk Guide, they added other steps in the algorithm, such as risk assessments, treatment for alternative diagnosis. But the sensitivity and specificity analysis was largely on the scoring system, which I'll show you next slide. So there's two: algorithm A, where chest X-ray is included, and algorithm B, where chest X-ray is not available. And you can see it looks rather complicated, but it's not really, in that it works its way through first deciding whether the child needs acute admission or referral because the child is very unwell, and then decisions around whether or not the child's at risk of having TB or not, and then working through issues such as, is there a specimen available, can TB be detected for bacteriological confirmation, is there a history of contact screening, and then getting to grading signs and symptoms and chest X-ray with a scoring system to end that result. Next slide. And this is the, just to show it more clearly, this is the signs and symptoms listed with scores, as well as the chest X-ray. So clearly chest X-ray is critical to this particular assessment. And this is the system that was evaluated with sensitivity and specificity using individual participant or patient analysis. Next slide. So, thank you. So, there are better ways of, next slide, please. So, there are better, perhaps there are newer imaging. There is newer imaging, as you know, CT scan, MRI, that is better at detecting TB often, or some of the pathology associated with TB more clearly. But this is not widely used, but it has been very useful, I think, in terms of evaluation of in diagnostic studies in more high resource settings. Next slide. The challenge I referred to was the detection of mediastinal lymphadenopathy or perihilar lymphadenopathy. And when you compare chest X-ray against, for example, a CT scan, you do recognize, and this study was done at Red Cross Hospital in Cape Town by very experienced radiologists, that chest X-ray doesn't have perfect sensitivity and specificity. And we do also recognize, and we've had this experience clinically many times, is that we all stand around and we struggle sometimes to agree on what we think is abnormal and what's normal in terms of, particularly in regards to lymphadenopathy. So there is always a problem of inter-observer agreement, along with the quality of the chest X-ray, etc. So it's a common challenge that we have, is the detection of lymphadenopathy by radiology. Next slide. Now, just in terms of the spectrum of disease and what else chest X-ray may be used for, chest X-ray is used often in prevalence surveys or for community screening, particularly in older adolescents and adults, as I've said. And it's been found that chest X-ray is very sensitive for disease detection, more so than the symptom screen. And when they do prevalence surveys in adults and adolescents, a third of the bacteriological confirmed cases often have no symptoms, but have an abnormal chest X-ray. So as a way of detecting and also ruling out disease, chest X-ray can be quite useful. But the situation in children, we don't have nearly as much information regarding that. And I think there's a different public health or community focus in terms of what you're trying to achieve through screening. And there is differences in terms of particularly specificity, but also interpretation, which make the use of chest X-ray in these contexts more challenging. And I think we need to learn more about that. Next slide. Also, in the context of contact screening and management, we've been happy over for quite some time to implement preventive treatment to asymptomatic young child contacts, even without testing for infection or without doing a chest X-ray to exclude disease. We're happy to do that on the basis of symptoms. There is now a lot of momentum in terms of expanding TB preventive treatment and also better regimens to follow that with. And one of the challenges, I think, as we expand regimens to include contacts of 5 years and older, and particularly adolescents, is the consideration of chest X-ray in that context. Next slide. So this is the WHO symptom-based screening that was put in 2006 when skin testing chest X-ray was not required. This is just a symptom-based approach to the management, and the only children who, in this context, who would receive a chest X-ray are those who are symptomatic, being evaluated for TB disease, but not children who were well under 5. They could go straight on to preventive treatment. And we did evaluate chest X-ray in this context in one study in Indonesia. And of the young child contacts who were well, the main chest X-ray abnormality was perihilar lymphadenopathy, which occurred in around 15%, but there was very poor inter-reader agreement as to which children actually had the lymphadenopathy. Next slide. Now that we're expanding, as I've said, TB preventive treatment for older contacts, there is likely to be the greater use of chest X-ray in that context. To be able to establish that if a chest X-ray is normal, then you can go ahead and give preventive treatment. Next slide. And this has also been included, this is recently published in the Gray Journal, in the Union Journal, in clinical standards for prevention of TB infection, is the inclusion of chest X-ray following a skin test or a test for infection. In those that were positive would receive a chest X-ray before they started preventive treatment. If that chest X-ray was abnormal, they would be first investigated for TB disease. Next slide, please. So to finish, lots of challenges, and Megan will talk more about challenges of quality and readability, and the Atlas is really strong on that. The challenges I've mentioned of sensitivity and specificity, trying to get that balance right, the challenges of inter-reader variability, and of course availability and accessibility. Now, training and teaching support is required. James and Simon and Megan and others have a lot of experience with this, and it's not just something you can do in an hour or two. It is quite a long, arduous process, and it often takes quite a long period of time and frequent exposure for people to develop the confidence. So it is a challenging area in that regard, I think, but I'll be interested to hear their perspectives. Final slide. So there are, I know people would like to hear on the fact that we now have digital chest X-ray modules that you can carry around in a backpack out into the community that are safer, lower radiation compared to previous X-ray machines, and can feed back to a computer that has a cutoff score with it that can interpret the chest X-ray as being abnormal or not abnormal, with performance, at least in adults, similar to radiologists. So that's the whole utility of computer-assisted devices and informed by artificial intelligence. But their utility in children is uncertain. We don't have information, particularly in children under 10, as to how this might work. Certainly computer-assisted devices can detect things like lymphadenopathy, but really, as far as I know, they haven't been carefully evaluated. And I think that's a process that's happening now. I do wonder, in the context of preventive treatment, for example, as I've talked about, whether they may have a potential role, at least in identifying what is a normal chest X-ray. So I'll finish there, and just next slide, and just thank everybody. I'm sorry about the confusion at the beginning, and happy to take questions. Thank you.
Thanks so much, Steve. That was a tour de force, a lovely whirlwind overview of chest X-rays and algorithms, and the place of chest X-rays in algorithms, and a bit of the history to it as well. I have I don't have any questions in the chat directly to Steve at the moment. There was a couple of questions about will the resources being presented be shared, and the answer is yes, they will, and there's a link in the chat. So if you do have any questions for Steve, please type them in now. But I'm going to ask Steve one question, which may be a bit harsh, and ask him, if you are the NTP manager in a country in Africa and you have $100,000 US to invest in child TB, where are you going to place it? Are you going to buy more X-ray machines? Are you going to train people to read X-ray machines better? Are you going to buy gene expert machines, or are you going to train people to diagnose TB clinically?
So I'm happy to admit to my bias. I would probably at the moment follow the experience, for example, of Uganda, of investing in strengthening the confidence of health workers at the primary and secondary care levels to make a diagnosis of TB. And of course, that will increase their exposure to chest X-rays and chest X-ray reading over time. But I'd probably start with the broader issues of knowledge around child TB diagnosis and treatment, and awareness of when to think about TB. And perhaps then if you give me more than $100,000, I'll move to more specific training on chest X-ray.
That's very helpful. Any other questions or comments from anyone? I could ask questions all day and I could come up with increasingly provocative ones, but we should maybe move on.
Thank you.
Thanks very much, Steve. We really appreciate it. And we know it's probably very late in the evening for you, so we appreciate it.
No, it's not too bad. I'll be listening in. Thank you.
The next speaker, we got a question coming up, so I missed that. So one for you, Steve, then. How sensitive is it to use stool for TB diagnostics in children, especially in settings where X-ray is not available using GeneX?
Yeah, no, fair question. And I think there is specific recommendations around the use of stool in the updated WHO guidance and operational handbook. I think we can simply say that I presented a slide on the role of expert. Those studies were largely from sputum, from induced sputum or gastric aspirate. The stool comes in a little bit under that. It's not as sensitive but there are certainly circumstances where the use of stool or nasopharyngeal aspirate might be more appropriate than trying to do induced sputum, for example, or gastric aspirate. So, yeah, I think it's still an imperfect test. It's not really a great improvement in terms of detection on any of the other approaches. It's just, it may be very applicable or useful in certain circumstances. Thank you.
Great. Okay, well, I'll let Steve opt out of further questions, but I'm going to move now on to introducing Dr. Megan Palmer, who's one of my colleagues and collaborators here at Desmond Tutu TB Centre in Cape Town. She's a paediatrician and she's been doing research on child TB for 10 years now. She has been traditionally doing diagnostic and treatment studies, but now is doing a PhD specifically evaluating the role of chest X-ray in the diagnosis of child TB and how X-rays can be used in clinical research. And Megan really drove the development and really did almost all the work for the development of this new atlas, which I think is a thoroughly impressive document. So Megan, tell us all about it.
Thanks, James, and thanks for that introduction. And I would like to just start by thanking the organizers for this opportunity. It's really lovely to be included in the lineup today. So as James said, I'm going to be taking you on a walkthrough of this diagnostic chest X-ray atlas. And I think I need to start off by saying it's a real whirlwind whistle-stop tour, because it's a almost 100-page document, and I'm going to try and give you an overview of the whole thing. So there is a lot of content, but I will share the link for the atlas at the end of the talk, and I promise you everything is in it. So if it feels like I'm whizzing through, then you can always go and have a look at the atlas yourself and recap what I've been talking about. Right. So I'm actually starting off with the first interpretation challenge around X-rays, and I'm not going to talk about this slide too much because this is really what Steve mentioned, but there are innate limitations of chest X-rays. So the interreader variability is a problem. The two-dimensional representation of a three-dimensional space is a problem, and we acknowledge these challenges, but we still believe there's a role for chest X-rays. So the atlas is divided into several sections, and I'm going to present 3 of them today, starting off with the first, which is assessing the technical quality of the chest X-ray and using a systematic approach to chest X-ray interpretation. Throughout my talk, I'm going to keep coming back to this algorithm because we really do try in the atlas to keep coming back to the algorithm, which takes you through a step-by-step approach to how you classify chest X-rays in children. So the first thing you do is make sure that you assess that it's an adequate technical quality of the form, and we do this by looking at rotation, penetration, and inspiration, but remembering first to check the projection, so whether it was an AP or PA form, sitting or supine, because this influences how you interpret it, and always looking for artifacts. And this X-ray just shows you that this opacification, apparent opacification, which was actually a braid or a plait on a child's hair. So when we look at acceptability, we look first at rotation, and you can see here on this form, if you look at these blue lines, they should be symmetrical on both sides. These are the anterior ribs, and those should be symmetrical on the right and the left. And then you identify the medial aspect of the clavicle, which is here in red, and you check that the distance from there to the spinous process, which you can see as this white dot, is equal on both sides. And it's important to do this because the commonest cause of a difference in radiolucency between the lungs, so the difference in whiteness and blackness of the lungs, is more likely due to problems with rotation than due to pathology. And here's just an example, so showing a really rotated chest X-ray, which you cannot interpret. Then we look at penetration. And this is, you can see this is all outlined in the atlas, so I won't go through all the details, but the one that I find most useful is you should just be able to see those intervertebral spaces through the heart and the mediastinum. If you can just make them out, then you probably have a well-penetrated form. And just to remember that over-penetrated forms will make the lungs appear much blacker, and under-penetrated forms will make the lungs appear much whiter. Here are some examples. So on the right-hand side of your screen, you can see what looks like a well-penetrated or normally penetrated chest X-ray. The one in the middle is very black and over-penetrated, and the one on the left is a little under-penetrated. And then we look at inspiration, and I think this is really important in children because we know how difficult it is to get well-inspired forms. You know, you can't ask a 9-month-old baby to take a breath and hold in. So it's very tricky for the radiographers to get these forms, and I think we must acknowledge that. But you need to be able to be confident in how you count ribs. And we've got this pictures taken out of the atlas, and on the left-hand side, you can see the white numbers. If you just follow my mouse, those are the posterior ribs, and then they curl anteriorly, and you can count 1, 2, 3, 4, 5. You should be able to see 5 whole anterior ribs above the diaphragm. In young children, it's better to use the posterior ribs, and you can see they're numbered in orange here, and you should be able to see 8 or 9 posterior ribs above the diaphragm. This is really one of my favorite chest X-rays to show the limitations of interpreting a poorly inspired form, because this X-ray was taken from the same child at the same time. And if you have a look at the one on your left-hand side and you count the posterior ribs, you can do it yourself, but I promise you, you can see that there are at least 8 or 9 above the diaphragm here. And on the right-hand X-ray, if you count, you can see 1, 2, 3, 4, 5, 6, 7. So this really is poorly inspired, and you can see an opacity here, a widening of the mediastinum here, and you may have seen pathology on that form that is actually not true pathology. And so that's the interpretation challenge number 2, is that there's a variable technical quality of chest X-rays, and you must make sure you assess this before you interpret the X-ray. So it's very important to use a systematic approach to chest X-ray classification, and this is true for adults and for children, of course. You can use any approach that you like. You don't have to use the one we recommend here, but just use one approach that you feel confident with and then use it consistently. So we've used the approach of the 3 structures that are white, 3 structures that are black, including 3 things in the lungs, and 3 features of the diaphragm and pleura. Okay, so you can have a look here on this side, this box, 3 structures that are white, so the soft tissue and bone, the upper mediastinum and the heart. And then on this side, the three structures that are black, really important in children, the trachea and the bronchi. So you start at the top, you trace down the trachea, you watch it split, and you should be able to see those airways. This is important in kids because we know that the airways can be involved in pulmonary tuberculosis in children due to compression of enlarged lymph nodes. There are three aspects of each lung. Look at the lung sizes, look at the hyperlucency. So are the lungs too black or too white? And look at the hilum, which is also very important in children, as you'll see in the next few slides. And then lastly, look at the stomach bubble. And then here on the left-hand side, the three aspects of the diaphragm and the pleura. So if you can also follow my mouse, you should trace the pleura all the way around the lung, looking for any thickening or opacification of the pleura within the pleural space. Always look at the costophrenic angle. So on the right-hand side here and on the left-hand side, they should be crisp. And look at the position of the diaphragm, remembering the right is usually a little higher than the left. And this slide is just really to give you a tip of how one looks at the lung parenchyma or the lung tissue. And it's useful to divide each lung into three zones because your eye can then really scan from left to right in the upper zone, left to right in the mid zone, and left to right in the lower zone to try and make sure that there's no abnormal opacification or lucency. So we have included a section in the atlas which looks at the lateral chest X-ray. So this is not everyone believes in doing lateral chest X-rays, but we really feel strongly that they're helpful. And I'll show you in a few moments about how they help you to look for lymph nodes, but they're also useful in terms of giving you certainty that there is pathology. So you might see something on the AP and you're not sure if it's artifact or real, and seeing it on the lateral adds certainty. And it also helps you localize a lesion. So it helps you decide where about in the lung the lesion is. And similarly with your AP or PF film, you must first check the quality is good. And just to highlight here, particularly the arms, make sure that they're not blocking too much of the lung field. They should be raised. So this is also, I think, a very useful picture to maybe keep up somewhere. It just shows the anatomy of the lateral film. I'm not going to go through all the numbers here just because we don't really have time, but I want to highlight number 4 here, which is the retrosternal space, because this is where anterior mediastinal structures sit, and of particular importance in young kids is the thymus. So in kids under 4, you might see that this is filled or there's a whiteness in that space, which can be normal because that's where the thymus sits. So just sticking with the thymus, this has also been given a fair amount of attention in the atlas because it's really can cause complications in chest X-ray interpretation, especially if one is a bit less experienced. And remembering what Steve said, that the diagnosis in the kids under the age of 5 or 4 is the most difficult. And it's exactly this age group where you will see a thymus. Okay, so the thymus is not visible in older children, older than the age of 4. And it's an anterior mediastinal structure. You can see the diagrams here. Although we learn about the classic sail sign or wave sign, which I'll show in the next slide, the thymus can really be any shape. And so if you see a widened upper mediastinum in a child under 4, you must just pause and make sure you're not looking at a thymus. Remembering that in the context within which we're talking now, of course, the diagnosis you don't want to miss is that there are lymph nodes in that mediastinum. So here's just an example of the classic sail sign. So you can see this triangular shape, and this is the sort of undulating or wave shape of the wave sign, which is a classic thymic shadow sign. So this is our third interpretation challenge. Chest X-rays look normal in children of different ages, so make sure you always know the age of the child. So the next section in the atlas that I want to address is the section which discusses the specific and less specific chest X-ray features for pediatric TB. And there are various ways of approaching chest X-ray classification in pediatric TB. So I want to just give a little background about why we chose this way. And this really is just to give you a quick overview of the slide. This is really showing how on the left-hand side over here, you've got a child with TB exposure or infection, no clinical symptoms and no X-ray abnormalities. And moving across the slide as you move towards the right, you have a child who has non-severe TB, and then all the way to this side, a child who has severe TB. And so this disease spectrum is really wide in children. And this makes it quite difficult to teach how to interpret chest X-rays for pediatric TB because there's such a broad radiological disease spectrum. And this really is interpretation challenge number 4. And so while we know that pediatric TB can look like anything on a chest X-ray, so the spectrum is completely wide, we also know that these two chest X-rays don't give the same level of certainty. So this X-ray on the left, where you can see this cavity, so this is a cavitating gonfocus, this X-ray really makes you far more sure that this child has TB than the chest X-ray on the right, which is normal, despite the fact that these both came from children with culture-confirmed TB. So TB can look like anything on the X-ray, but there are some features that are more specific than others. So I'm just going to use this framework. This is a sort of simplified version of the pathogenesis of the radiological features of TB in children. I'm not going to work through it now, but as I go through some of the patterns, I'll use this just to orientate you. So remembering, we keep coming back to this algorithmic approach. We've looked at the technical quality of the chest X-ray. You've used a systematic approach to decide if it's normal or not. And now we're sitting here where we're looking for the features specific or less specific to TB. So the chest X-ray features that we classify as being very specific to TB are a gonfocus or complex, lymph node disease, Milory Tb, pleural effusions, and cavitary disease. And then there are some other less common patterns. So working through these first, so a primary or a gonfocus or complex, so when the child inhales the bacilli, it moves down the airways and goes into the lung parenchyma and causes a reaction. And this is what you see. This is called a primary or a gonfocus. It's really uncommon to see this alone. And the reason for that is this happens very early after inhalation of the bacillus infection, and the child's often asymptomatic at this stage or minimally symptomatic. And so it's very unlikely that a chest X-ray even gets taken. What is more common is that you see this pattern where you can see here's the gonfocus, but there's an associated enlargement of the lymph nodes here. And this together, the gonfocus with the lymph nodes together, is called a gon or primary complex. And you would see this more commonly than the gonfocus on its own. So from the gonfocus, the organism there can be progression where the organism gets carried by the lymphatics to the local lymph nodes. And this is when a child develops lymph node disease, which can be complicated or uncomplicated. And really, Steve alluded to this already, but the hallmark of pediatric TB is enlargement of the mediastinal lymph nodes. So this is a really important feature to try and spot on chest X-ray, but we acknowledge, as has been mentioned, that there is wide interreader variability, and it's not as easy as one would think when you look at the perfect chest X-rays. In the real world, it's not always so easy. But just remembering the shape here of the normal hilum, so it's sort of a concave shape inwards. Some people talk about there being like a tip or a corner to this hilum or a Y shape, but that is normal, the X-ray A here. And on this side, you can see this bulging of the hilum or a lobulated structure that's sitting there. Just remembering the pulmonary vessels all come out of the hilum, so it is a busy area, which is why it's difficult to interpret. But your hilar vessels normally splay outwards almost like the branches of a tree, whereas a lymph node should be more of a round lobulated shape. And here's just another example showing a widened upper mediastinum with a opacity that's bulging outwards. Okay, this is the lateral film, and just showing one of the reasons why lateral chest X-rays are really helpful. So this X-ray A here, this is a normal lateral chest X-ray, and this is obviously very abnormal. And I acknowledge you're probably unlikely to ever see such obvious lymph nodes in your career. So this is obviously a very gross example. But we're using it here to try and highlight these signs here, which is called the sign here, which is called the donut or hamburger sign. So the central or the whole of the donut is made up of the bottom of the trachea down here. So you can see the trachea comes down. This is where it would end or bifurcate. That's the hole in the middle of the donut. And you can see that the opacities go all the way around here. So at the top here, or the upper part over here, you can sometimes have opacities that are normal because the normal blood vessels run there. But if you see the whole donut being completed at the bottom, then you know that you're probably looking at lymph nodes. And then in X-ray D here, this is just another trick you can use where you make a line down the trachea as a vertical line, and then you form a cross. And certainly in this quadrant, there's never any normal blood vessels there. So opacities in this quadrant are always abnormal. But in a case like this, obviously all of these opacities are abnormal lymph nodes. So lymph node disease can be uncomplicated and complicated. And you can recap this in the atlas. You don't have to remember this all right now, but complicated lymph node disease includes lymph node disease where there's airway compression or associated hyperinflation or collapse or extensive involvement of the lung parenchyma. So just looking at the airway compression, remembering that you might see airway compression without actually seeing the lymph nodes, and that's why it's really important to always trace the airways on the X-ray. So here's an example. You can see the arrow there pointing at narrowing of the left main bronchus, and that's a very classic sign of complicated lymph node disease in children where the airway gets squashed between two lymph nodes. And here's another example. There we go. So you can see here at the proximal end of this bronchus, the caliber or the caliber of this airway looks normal, and then down here it gets far more narrowed. And so this really is showing you a compression of the airway and very, very suggestive of lymph node disease. Okay, and then the next criteria that you can use to decide whether lymph node disease is complicated is whether you see associated hyperinflation or collapse. And this is a very classic example of what we call a check valve or ball valve effect. And you can see here when you use your systematic approach, you can clearly see that the left lung is much larger than the right lung, and this diaphragm is flat and pushed down. So this is a consequence of there being lymph nodes sitting here on the left, allowing air into the lung, but then the air gets trapped and it can't exit the lung. So it's like a ball valve effect. So this lung gets more and more full of air and it starts to push the mediastinum across and push the diaphragm down. Here's an example of collapse. So this is a pattern that's quite easy to miss because this collapse sits right behind the heart. But once you've seen this pattern once, you probably won't miss it again. There's like this triangular pacification behind the heart. And this is when the lymph nodes completely block the airway so that no air can get into that lung or segment. Then the third very specific pattern of pulmonary TB in children is Milory Tb. And I think we all know that this occurs when the TB bacilli is now accesses the blood circulation and disseminates throughout the body. So children with Milory TB, you should always look for involvement of the liver, the spleen, and the brain. Look for TB meningitis. So here's your classic picture of Milory TB, and you can see in the bottom a picture of the millet seeds. This is where the name comes from. So it looks like lots of little small nodules scattered throughout the lungs, all the way out to the peripheries on both sides. And here's another example. And just to remember, in areas where you're still seeing a lot of HIV in children, it's quite difficult to distinguish radiologically Milory from LIP, but the clinical picture actually helps you really more than the chest X-ray does. And then we have pleural effusions. So this is an example. I think the pleural effusion is a pattern that's a little more easy for us to all see on chest X-ray. Here's a classic pleural effusion with this meniscus shape here on the right-hand side and the costophrenic angle that you cannot clearly see. And this is we would call a simple pleural effusion. So this is an example of a complicated pleural effusion. And if you just trace around here where my mouse is going, you can see this opacification sitting in the pleural space here with this shape. It does not have that meniscus shape like you saw in the previous X-ray. And this tells you that this is a loculated effusion or an effusion that's become organized. And this is a severe chest X-ray pattern. And noting also that there's a lot of involvement of the underlying lung here. You can see the right lung here is very white. So that would be another indication that this is severe disease. And then the last pattern that I'm going to highlight under the sort of specific chest X-ray features is cavitary disease. And in children, cavitary disease can develop as primary progressive disease. So what this means is you have primary infection, involvement of the lung parenchyma that does not become contained, or the child does not get treated. And so necrosis develops and you get cavity formation. Or children can develop post-primary TB where the chest X-ray pattern will be similar to that seen in adults. Here's an example of what is probably a cavitating gone focus. So this area was probably a gone focus. If you can remember what that one looked like on chest X-ray, this was maybe not treated, or the child was not able to contain this disease. And so you can see the necrosis and cavity formation in the center there. So this would be primary progressive TB. And here's an example of classic adult type cavitary disease with bilateral cavities, remembering they often involve the upper lobes or the apices of the lower lobes. Okay, and so we've looked at the features that are more specific to TB, and then just coming to the features that are less specific to TB. I think very important at this stage to say that these features are still commonly seen in children with TB. So the implication of calling them less specific is not that you don't see these in kids with TB. It's just that if you see something like an alveolar classification or consolidation, it's difficult on the X-ray to say whether that's a bacterial pneumonia or tuberculosis. So it's less specific, but they're still quite commonly seen. So really here the feature that I'm mostly going to focus on is alveolar pacification, which can be segmental or lobar, and then there are other infiltrates. So this is a little bit of a discussion of terminology because I think it can be confusing, but when we talk about alveolar pacification, we really mean consolidation, or what some people call airspace disease. So this is pathology sitting in the airspaces or in the alveoli. And you see this as dense, often homogeneous, confluent infiltrates in the lungs. And it can involve an entire lobe, and then we call it lobar, or less than a lobe, and then we call it segmental. Okay, so here's an example, and I realize this is a very pixelated X-ray, it doesn't project very well, but you can see this lung here looks more white, and this is the right upper lobe. But the top of this lobe, or the apex of this lobe, is spared. So this is a segmental opacification or a segmental consolidation. And you compare that to this X-ray where you can see the entire right upper lobe is involved. So this is lobar. Okay, so that was a lot of information, but we're going to move now on to classifying radiological disease severity on chest X-ray. And I'm just coming back to the slide just to remind everyone that there is this disease spectrum from all the way from non-severe disease to severe disease. And we now know, based on the latest WHO treatment guidelines, that there is now going to be a move towards treating children for different durations based on disease severity. So these X-rays on your film would say, well, this child who has cavitary disease should receive a normal treatment duration, which is currently 6 months. But this child who has non-severe, or in this case, it's actually a normal chest X-ray, could be treated for shorter. And the guidance in the WHO guidelines came from the SHINE trial. And so the disease severity classification suggested is directly taken out of what was used in the SHINE trial. And I think also just to pause at this point to say that this is obviously in the WHO guidelines. As far as I know, it has not been included in national treatment guidelines yet. So I think within all our respective countries, we're waiting to see when it gets included so that we can implement this. So if you come back to your algorithm, you now at this point here, you've decided to treat the child for TB. And in the near future, you'll have to then decide if it's radiologically severe or non-severe. So severe disease includes any of the following. So it's complicated lymph node disease, and you can see in the gray block or remember what that is. It's alveolar pacification or consolidation that involves a whole lobe or more than one lobe. It's cavitary disease, and it's Milory Tb, and it's complicated pleural effusion. So in the atlas, the way we've approached this is when in each section, each chest X-ray pattern section, such as uncomplicated lymph node disease, you can see here, we've included infographics, which will tell you whether this is a severe or non-severe pattern. And then there's also these chest X-ray infographics in a tabulated format that can be easily printed, just summarizing which patterns are severe and which patterns are non-severe. Okay, and then these are also just excerpts from the atlas. So you will have there, for example, a section such as this showing you a primary gone focus, and then the infographic at the bottom telling you that this is non-severe disease compared to cavitary disease on your right, which is an example of severe disease. And here you can see on your left, uncomplicated lymph node disease. So I don't know how well it's projecting for you, but the airways are not involved in that picture. There's just a large lymph node on the left hilum, and the lung fields are spared. So that's non-severe, compared with complicated lymph node disease on the right of your screen, where you can see involvement of the airways. So just to wrap this all up, I wanted to just present a case to try and convince us whether we still think X-rays are useful. So we know there are limitations, but I really do believe that X-rays are still useful. And I think this is a good example. So you see a 1-year-old boy who's been coughing for 5 days with intermittent wheeze and fever for 2 days. There's no clinic card. Sorry, that's a road to health card in South Africa. So you haven't seen a growth chart, but the mom thinks he might not be growing. There's no known TB source case, but someone's coughing at home. There's no TST in stock. Would you treat this child for TB? And I think based on this clinical presentation, you've got a short history, you don't have any confirmation of TB exposure or infection. So you really at this stage can't be confident that this is TB. You do a chest x-ray, which looks like this. This chest x-ray looks like essentially normal. There's nothing here that's specific to TB. So in a case like this, you might decide to treat this child for a lower respiratory tract infection and review. I don't think you've really got evidence that this is tuberculosis. But what if the chest x-ray looked like this? So in this case, you've got features very specific to TB. You've got enlarged lymph nodes here on the side, on the paratracheal and perihilar on the right, and you've got an opacification on the right-hand side. So in a case like this, the chest x-ray is very helpful. When you have a less typical clinical presentation, but very specific chest x-ray features. And then of course, in the next, hopefully the next few months or the next year, we'll all start having to decide whether to treat this child for 4 versus 6 months. And in this case, it would be 6 months because this is severe disease. So chest x-rays are not perfect, but they are still very useful. And here's the link at the bottom of the slide, so you can access the atlas if you have not got that already and cover all the stuff that I've already covered in this very whirlwind tour of the atlas. Just want to thank and acknowledge everyone on this slide. So my mentor, Rob Gee, my co-authors, the union for funding this work, and other colleagues and collaborators, and of course, the hundreds of chest x-rays from whom hundreds of children from whom these chest x-rays were taken. Thank you.
Thanks, Megan. That was a great summary. I was very uncertain you'd be able to cover everything in half an hour, but you've done an amazing job of giving a full feeling of what the whole atlas is going to include. So we haven't got too many questions. I think there's one question which may probably go to your Steve, but I'll ask you just to say, what would be the best way to monitor TB cases that are clinically diagnosed, assuming with taking into account that they could have any other condition, as you've indicated in your presentation, Megan?
So you're talking about a child, okay, so a child with clinically diagnosed TB who starts treatment, and how do you monitor them? So I think that we don't have a lot of evidence about the best way to actually monitor treatment response in children, but primarily you would do that clinically, so symptom resolution and weight gain. And then in some places we do repeat x-rays, and I think that can be useful, but we don't have evidence to say that that is useful. So I would say it's mostly a clinical response to treatment that you're looking for.
I mean, if you've not got TB and you've got some other cause for your symptoms, you're going to be better on TB treatment anyway.
Perhaps. I guess it depends what the other cause for the symptoms is.
No, I think that the lesson from that really is that if you make a clinical diagnosis of TB, you need to still in the back of your mind keep thinking and don't switch off and think this has to be TB. If you make a clinical diagnosis, you keep following that child, and if they're not getting better or something continues happening, just at the back of your mind, keep thinking, is there another diagnosis I'm missing? Could this be a cancer? Could this be some other problem that's causing these symptoms? I think, if you've got a confirmed diagnosis, to some extent you can switch off and think, I'm pretty certain this is TB, but with a clinical diagnosis, you need to keep going. Okay, Megan, I'm going to ask you an unpleasant question. The data-driven algorithm which produced for WHO was quite similar. The sensitivities were set at 85% and the specificities with X-ray were 35%, but without X-rays were 30%. So not actually much difference with the addition of X-rays. So that kind of suggests X-rays aren't really offering much to the diagnosis of child TB. How would you do a study to show whether X-rays actually make any difference to the diagnosis of child TB?
So James, I think it's a really good question. And I think that for me, the way I see X-rays, I'm very cognizant of their limitations. So I think that we have to know when they don't help. And it's important to acknowledge that, because we know there are limitations, but when you have a very clear chest X-ray picture, then it really is very helpful. And given that we have so few good diagnostic tools in pediatric TB, I think we need to use everything that we have got. So how I would do a study like that, and what I actually am hoping to do at some point, would be to set up a set of different cases where you have a clinical presentation of TB in a child, and you get people to assess their certainty of how certain they are the child has TB based on the clinical presentation. And then you give them a chest x-ray, or even perhaps at a later time when they sort of don't remember what they said about the case, you ask them to make the assessment with a chest x-ray, and then you try and get a sense of how much the chest x-ray really contributed to their decision making. I think that would be really, really interesting.
No, great. Well, thank you very much, Megan, for a great talk and great answers. And we'll move on because we've got about 25 minutes left. And I know I want to be respect everyone's time and finish on the hour. And it gives me great pleasure to next introduce Simon Scarf, who I think many of you will know, who's a professor here at Stellenbosch University in the Department of Pediatrics, who's been doing research and looking after children with TB for many, many years, and is a really world acknowledged expert on child TB and drug-resistant TB in particular. So, Simon, are you going to share your screen, or shall I share my screen for the cases?
I think you can share your screen. Thank you, James, because I'm not sure whether I've got that correct. Okay, so can people see my slides? I'm hoping they can see them. And these are cases that have been sent in by individuals on this call. And this is a case from Tanzania, and I'm going to summarize, I'm going to read the history and show the x-ray, and then ask Simon for his thoughts to talk us through it. So this is a 2-year-old boy who presents with a history of cough and fever for more than 2 weeks, associated with lethargy and a loss of appetite. And on examination, on clinical examination, there are peripheral enlarged lymph nodes. And we see this x-ray. Okay, so for the time being, I'll ignore the part at the bottom and just try to read the x-ray. I think the first important aspect is to look at the quality of the x-ray as identification, of course. First, make sure that you're reading the right x-ray, the correct date, because that is important for the child. And then to look at the quality. And one of the aspects of the quality on this x-ray is that we cannot actually see the top of the x-ray, so it's difficult to count the ribs. But if we do count and think that this is the first rib, it's 4 anterior ribs that we can see, and posterior ribs probably 1, 2, 3, 4, 5, 6, 7. So it's not the best inspiration, but it's I think it's still readable. It's slightly underpenetrated because one cannot see the intervertebral spaces through the heart shadow. So it's a little bit more white than overall the X-ray than one would want it to be. And then looking at rotation, we cannot see the clavicles. But if one looks at the anterior ends of the ribs, if I look at it, it looks like the left side is a bit shorter than the right, but it's probably okay still. And then we start looking for the pathology, and the pathology, we go through the process. I like the 3 blacks, 3 whites. So let's start with the airways, and because it's underpenetrated, it's very difficult to see the airways in the specific chest X-ray. Because with underpenetrated X-rays, the airways can't be seen very well. Overpenetrated X-rays, one can actually see it much better. And sometimes we used to do an overpenetrated X-ray just to see the airways properly. So that is something that we cannot use in this specific patient, but you can see the trachea and it looks central. The second black thing would be the lungs and the size of the lungs. The left lung slightly smaller than the right. And then with that also the hilar areas, and the right hilar area is quite full. And I usually refer to a Y shape. It should be vessels running up, vessels running down. But this is quite full, and I would think that in this case, it looks like there are lymph nodes on the right. And then the third black thing would be the stomach bubble. I cannot see the stomach bubble, so I suppose this would be a supine X-ray where often you can't see the stomach bubble because of the fluid lying flat in the abdomen. But the reason for looking at the stomach bubble is just to see whether there's any pathology below the diaphragm and also the diaphragm itself. The three white things will be the soft tissue and bones, which we can't see much of, but very important always when you look for TB, also look at the spine and make sure that there's no paraspinal abscess or collapse of vertebrae, which we cannot see. The heart size looks within normal limits in this case. And then the upper mediastinum will depend very much on the age of the child. Is there a thymus, or would we expect a thymus at the age of the child? And I think this child was 2 years old, so thymus is quite possible. But we do know that with severe malnutrition, as well as with chronic disease, the thymus will eventually disappear. And if you find a wide upper mediastinum in a child that's severely malnourished or very ill, that is probably also other pathology, not the thymus. But in this case, what I can see is that there are right hilar lymphadenopathy. I don't see any pleural effusion. If one look at the pleural, the cosophrenic angles are sharp. And I think we've more or less covered everything in this case. So it looks, with the history and the chest X-ray, I would definitely consider a tuberculosis. And I think in that case, it is important to, if we have the facility or the infrastructure to do further testing, and in this case, it seems like an expert was done. It says MTB positive, and then trace positive. And the question is trace positive actually positive? And my experience is that in most cases it is. And I do think the WHO also interprets or says that we should interpret it as positive if we find the organism, even if it's trace positive. But unfortunately, with trace positive, you don't get the sensitivity for rifampicin.
Great, thank you very much, Simon. That's a very comprehensive review of that. We've got several X-rays to look at, so we'll move on to the next X-ray. So this doesn't have a clinical history with it. Does anyone who sent this X-ray from Mozambique want to speak up, if they want to unmute themselves and give a 30-second clinical history for this X-ray? If there's no one from Mozambique who sent this X-ray, then we'll ask someone just to have a look at it and report it without the clinical details. But if the person who sent this is on the call, maybe unmute yourself and tell us what's here.
Okay, so
okay,
I
well,
don't hear anything.
Go ahead, then.
Yeah, so again, of course, date and correct patient, and then to evaluate the quality of the X-ray. And again, 1, 2, 3, 4, 5, 6, 7 posterior ribs, and 1, 2, 3, 4, 5 posterior ribs. So not the best inspiration if one counts the posterior ribs specifically. Penetration looks fine. One can just see the intervertebral spaces, and in this case again, the clavicles are very difficult to see, but we mostly use the anterior ends of the ribs, and it seems like it is, if it is rotated, it's very slight. I think it's probably not rotated, but it's actually not a very good inspiratory X-ray. Now I'm just going to start off with a lot of interpretation, in the sense of there's a lot of artifacts, which is most likely, if I look at the tubing, it looks like it's a patient being an Occident, and we know that children with tuberculosis is not often in need of Occident, so one starts thinking of more acute disease, except if it's an ARDS type of response or severe infiltrates with tuberculosis. So one should be careful also of the severity of the disease and the need for oxygen, because the children with TB are usually not acutely or that acutely ill. So again, going through the three blacks, we can see the airways. It's not a good inspiratory X-ray, so one should be very careful in interpreting compression of the airways if it's not a good inspiratory X-ray. For compression of the airways, you actually do need a good inspiratory X-ray. In this case, it looks if the left main bronchus might be slightly narrowed, but I think it's most likely due to the fact that it's not a very good inspiratory X-ray. The lung fields and it's moved to the right, and the reason is if you look at the top here, it's kinked, and it always goes to the right because our aorta is on the left. And if one breathes out or takes an X-ray in expiration, then the trachea will move to the right. Regarding the lung fields, if one compares the right to the left, it certainly looks like there's some infiltrates in the right upper lobe, because the right upper lobe area or the upper zone area looks more white than on the left. Even the mid zone may be slightly more opacified on the right. And then, James, you can just indicate the right heart border, the area next to the right heart border. What we call that heart border is sharp, so there's nothing in the right middle lobe, or unlikely to be something in the right middle lobe, but there is some streakiness. And that is often called the freshman's forest, because a lot of blood vessels run down in that area, which is on the left behind the heart, so you don't see it. And if you only see pathology or so-called pathology in that area, be very careful of that could just be the normal blood vessels running down to the lower lobe posteriorly, because it's not against the heart border, so it's not right middle lobe. It may be, and that is where the lateral will be helpful, there may be some opacification in the anterior segment of the lower lobe in the specific case, because there's also some other pathology in the lungs. Regarding the highlight areas, because of the other classification, very difficult to say whether they are lymph nodes. It doesn't specifically look like lymph nodes to me. And then the third black thing is again the stomach bubble. I think again this is a AP, most likely supine. So what you see is gas in the most likely the colon. The right diaphragm is a little bit higher than the left, which it should be. And then going through the white things, so soft tissue and bones, I don't see any pathology that specifically concerns me. Also with the spine looks normal. The heart looks normal in size, and remember that even if the heart is slightly big on a supine X-ray, AP supine X-ray, it could just be positional, and one actually needs an erect X-ray to look at the size of the heart, or to judge the size of the heart. And then the upper mediastinum, in this case, I think is within normal limits. It is most likely a young child with a normal mediastinum. So in my view, this looks much more like a pneumonia than it looks like tuberculosis. But as Megan said, if the history indicates a longer period of disease or loss of weight or TB contact, then one has to reconsider. But on the chest X-ray only, with no other information, I would not diagnose TB.
Thanks, Simon. No, very nice interpretation. I agree. It's not a perfect film, but I think you've got some patchy changes here and no obvious lymphadenopathy, so that's useful to know. Okay, next X-ray. Maybe have a couple more X-rays, one from Tanzania and one from Mozambique. This is a 12-year-old girl who's presenting with a history of cough and weight loss and failure to thrive and repeated febrile episodes. And we see this X-ray, and yeah, we've got somewhat answers beforehand.
Yeah, and unfortunately in some way, but I think the history is also quite indicative of what we would expect to find. Again, unfortunately, the X-ray is not complete in the sense of that the complete bottom part of all the costophrenic angles and the diaphragms are cut out of the picture, which is unfortunate, because that is something sometimes very helpful. I suppose this one would call an over-penetrated chest X-ray because you can clearly see the intervertebral spaces and the lung fields on both sides actually look very black. And the problem with that is you can actually now see the airways quite well, but the pathology in the lungs is obscured by the fact that it's much too black. So you see less of the pathology than you would expect. And still one sees a lot of pathology in the lungs of this patient. So rotation, I don't think it's rotated, and inspiration we cannot actually judge, but it looks fine. Just I can't count all the ribs specifically, but it looks with good inspiration. So again, going through the system, the three black things, looking at the airways look reasonably fine. I can follow them through, and they don't look like they compressed. And then the lungs, one can clearly see that there is a lot of pathology, and unfortunately, one cannot see all the pathology, but definitely left mid zone, even left lower zone, left upper zone, and even the right upper zone is not normal. One can see some infiltration in the right upper lobe. One gets the impression that there may be a higher opacification on the right, and with the other pathology that I can see, the cavities on the left-hand side of the left mid-zone, there are definitely cavities. One would be less inclined to call this lymph nodes. It may just be more opacification, but this to me looks like adult type disease. What one would also want to know in an X-ray like this is whether the child has underlying other pathologies such as HIV, because with bronchiectasis and so on, one can get a very similar picture, especially with the lower lobe. So this could be chronic lung disease. But the cavities makes one, the larger cavities makes one think that this is most likely tuberculosis. Stomach bubble I can't see. The bones look fine. The spine I don't see. You can actually see the spine quite well, but I can't specifically see a paraspinal abscess or collapse of a vertebrae. Lateral would be better for that. And then the upper mediastinum should be narrow because there should be no thymus, but this is a very narrow upper mediastinum, and we don't almost see no soft tissue, so probably a very thin child. And I'm not surprised that the gene expert is positive.
Simon, and we'll move to the final case, and I don't think we've got any history, so if someone you could have a look at this and just give us your thoughts.
Okay, so unfortunately, again, no age involved, but so in this case, I would count the ribs on the left because I can't exactly see where it stops on the right. So it's 1, 2, 3, 4, 5, 6, 7, 8. Almost 9 ribs on the left-hand side, so that's good inspiration. It's not too lordotic because the clavicles are visible, but they're not very low down in the lung fields. And a lordotic X-ray can make the higher areas much more prominent. So one actually wants the clavicles quite high up in a child. When you do X-ray in an adult, you actually want to see the apices of the lungs. So often the lordotic picture is good for an adult to do for TB screening. The X-ray is not rotated, and the penetration is fine because you can actually see the intervertebral spaces through the heart shadow and through the mediastinum. So again, starting with the airways, the 3 black things, one follows through the trachea, that looks fine, but then at the distal end of the right main bronchus, that looks like it starts to narrow, James. Yes, over there. The left main bronchus, some uncertainty if there's narrowing distally. The lung fields are clearly opacified on the right, but even the left doesn't seem normal. So there's opacification in the right upper zone, but there's a collapse of the right lower lobe, and one can see and it's probably mid lobe as well as lower lobe, because you can see the horizontal fissure being pulled down. And there may be areas of breakdown in that collapsed lung at the bottom. And then, as I said, upper zone, there's also some opacification, and there may also be some cavitation in that opacification. Behind the heart on the left, I am quite convinced that there must be some opacification as well, because you can see the air bronchograms, and you can't follow the diaphragm further than the heart shadow. So I suppose there's some pathology in the left lower lobe as well. In this case, one cannot clearly see any lymph nodes, but there is compression of the airways, and I don't see any foreign object. That's the other thing that one has to consider when they see an X-ray with a collapse. And the history will be very important. Is it a very acute history of choking or not? I said I see no lymph nodes, but I haven't done the white things yet, and I'll get to it. I don't see any very high lymph nodes. But one has to get to the history, what exactly happened in this patient, and most likely the patient has been coughing for quite a while. The white things, quite a thin child, very little soft tissue. The bony structure looks fine. I don't see any swelling in the neck, because you can see the neck. And then I don't see any vertebral opacities or paravertebral opacities. The mediastinum in a very thin child, very ill child, is wide, and it's rounded convex. I think there are paratracheal nodes on the right-hand side. I didn't mention with the black things the stomach bubble, but you can see the stomach bubble. You cannot see the right diaphragm at all. I don't think there's a large effusion. I think it has to do with a complete collapse of that of the lobes on the right. What have I missed now? I think I've covered more or less everything.
No, that's brilliant. Thank you very much, Simon. And I think that this is pretty characteristically TB.
Yeah.
Great. I think that we're going to have to call that a day, because we've only got a couple of minutes left. But thank you very much, Simon, for giving us this X-ray. I mean, I could listen to this for hours, but really what we're trying to do with reading these X-rays is give you an idea of the system. It's not about the individual patterns so much, because there are so many different patterns to look at. It's more just showing you how to systematically and very thoroughly go through an X-ray and evaluate it, and then you don't miss stuff. So watching Simon do this is a real work of art, and he's been doing this for many years. So thank you very much.
So James, just one comment. My students always ask me, should I start from the beginning? You always have to start from the beginning. I've been reading X-ray for quite a number of years, but it's actually important to make sure that you always start from the beginning and go through all the processes, identifying quality, and then reading the X-ray, because if you do not do that, you will certainly make mistakes.
Absolutely. Well, look, I think we need to call it a day. There is one comment from Steve, who responded by a slightly provocative question and highlighted that in addition to sensitivity and specificity, there are important other considerations, operational questions about whether you can increase case detection and management. And absolutely, I wasn't denying that. And the other thing about chest X-rays, it's not just a tool to diagnose TB. It can be useful in many aspects of child health. So it's a really important tool to have in primary and secondary care. So it gives me enormous pleasure to draw this to an end. I don't know if John Paul, you have something you want to say to finally, but on behalf of myself and Simon and Steve and Megan, thank you all very much for attending. We hope this has been useful. It will be recorded, and all the resources will be placed online on the Union website. So John Paul.
Thank you so much, James. Again, really to thank all our country representatives, all the participants, yourself, Megan, Simone, and everyone else, really, Steve, who have been able to join us today. We'd really appreciate your time and giving this session that much credit that it deserves, and having a very good session. But James, we have a few discussions we want to discuss with country colleagues. I know you have to drop off for another session, so it's just okay for you and colleagues to drop off such that we're able to continue with our country colleagues for just about 10 more minutes. Yeah, so happy for you to drop off as we
Absolute
get on.
pleasure.
Thank you so much.
Thank you for a really good session. Really appreciate it.
Thank you so much,
Thanks,
James.
everyone.
Good.
Thank you very much.
Bye-bye. Thank you, everybody.
Thanks, Megan.
Thank you, Megan. As our colleagues drop off, country colleagues, again, thank you so much for joining us today. But of course, really special thanks to our team from Mozambique and Tanzania, who are able to give us some good chest X-ray films that we've been able to go over. But we wanted to run some poll questions. These are really very specific to our COE country representatives. And as I looked through the list of people on the call, I think I saw Charles Sunday, I saw Christine Wambugu, I saw Cremenia, Jacqueline, Kevin, and Alan. So the poll that we want to run are really guided to our country representatives, and these polls really are intended to continue guiding us on our priority activities for the COE, but also making sure that the things that we want to do are mutually agreed on with our COE country colleagues. So I'm going to run the polls, and again, my colleagues Amalia, Selma, I think I've seen you on the call. If you have anything additional, please go ahead and speak as we run the calls. We have about 4 questions on the polls, and we just want to pick a bit of your mind on some of these proposed activities I want to do towards before the end of this year, but also activities we'll be doing in 2023. So I would launch the calls now, and I'll let you guys go on and respond to the questions.
Hello.
Yes, Jacqueline, please go ahead.
Yeah, I won't be able to participate because I'm on the road, I'm driving. So kindly just excuse me. Thank you. Thank you so much.
We'll definitely get to you probably in a question format, and we'll be able to get your responses.
Thank you. I really appreciate that. Thank you.
Thank you, Jacqueline. So guys, please go ahead and respond to the polls, specifically for Charles, Christine, Cremenia, Kevin, and Alan. Over.
I don't phone you.
Amalia, do you want to say something, Amalia?
Yeah, hey, John Paul. On my side, I don't see any way to answer the questions. I don't know if others are having this challenge. I'm not sure what's happening.
Are you having the same, Selma?
I can see the questions. The poll questions have come up at my end, John Paul. I'm able to, if I want to, I can respond to them.
Okay, great.
So, Paul, how can we link this poll? Because I can see there is option of tick, and I can see the best way I can. Okay, I can rank. How can you explain to us, please?
Maybe there's a Zoom issue then as we're entering the questions. Maybe are the rest all having the same problem?
Now I see 2 out of 45 people have been able to respond.
No, we only need about 6 people, the country representatives.
No, yeah, I know. I'm just looking at the response.
Yeah.
Well, John Paul, there is no way to list to kind of list the priority. So you can tick what you want, but I don't see where we can put this. So if I tick it, it doesn't give me an opportunity to put the priority.
Yeah, I think these are multiple choice questions, John Paul. They're not ranking questions.
Okay, then maybe I think we'll have to share this with our country colleagues to rank. I guess that's probably the other option we could maybe follow on. But also I think we have our next webinar on the 2nd of June. But before then, I think we can run some polls with our membership and be able to see how to have this ranked in a different way.
Yeah, thanks, John Paul. I think if we send this out via email to our COE country colleagues, that would be best.
Great, thank you. So I think, guys, there's a problem with the poll on Zoom. So we're not really able to actually get the right ranking that we're looking out for. So we'll send out these questions again. We'll probably do a quick Survey Monkey for these questions and allow you guys to rank this for us as they get to you, and we'll try and follow up with you so we can have this feedback really pretty in as fast as possible. So if we can't really proceed to do this, I would probably want to also thank all of you really for having joined us on this session. We're definitely going to share the recording for this session, but we'll also post this on the COE page so you're able to view, but also continue to share the recording with all your different colleagues in your member country. So unless if my colleagues have anything to say, Rita, Amalia, if you have anything additional to say, I'd want to close the webinar. Great. I think no additional comments from my colleagues, so happy to close the webinar and see you again soon.
Thank you.
Thank you. Bye-bye.
Bye-bye.